Thank you very much. I'll be presenting the examination findings, follow-up, and the investigations. So now, starting with the general exam, child was sick looking, had severe pallor, no jaundice, it was febrile, there was no dehydration, no lymphadenopathy, no edema, no cyanosis, no fingernail clubbing, and there were no any dysmorphic features. So the temperature was at 38.1, the height was 115 centimeters, weight was 19 kilograms, and the BMI was 14.4. On abdominal examination, there was moderate distension, the abdomen was soft, moving with respiration, no scars, and there were no visible collaterals. And there was a moderate epigastric tenderness. The hepatomegaly was 2 centimeters below the right subcostal margin. There was the spleen was not palpable. Bowel sounds present, but of reduced intensity. On PR, there was normal sphincter tone. There were small pellets of stool on the examining finger, no blood. On the respiratory exam, there was no the child was not in distress, had a respiratory rate of 31 breaths per minute. The SpO2 was at 98%, normal breath sounds had, and had vocal resonance bilaterally. There were also no added sounds. On cardiovascular exam, the pulse rate was 114 beats per minute, regular and of normal volume. The blood pressure was 97/50 millimeters of mercury, and the capillary refill was at less than 2 seconds. Heart sounds 1 and 2 had, and there were no added sounds. Cns exam, the child was fully alert, neck was soft, Carnegie sign was negative, there were no craniopathies, and there were also no focal neurological deficits. There was normal tone, normal power, coordination in all the limbs. So we had an impression of severe malaria anemia, and we also thought of ruling out enteric fever, partial intestinal obstruction, upper GI bleeding because of the black stool, and then sepsis. So the investigations that we did, we had the CBC that was done, the LFTs and the RFTs, and the results were as follows. So on arrival, we had an HB of 4.5 grams per deciliter, platelet count of 14,000, white blood count of 9,530, and the red blood cells were 3.026 per liter. The LFTs, we had the ALT, that was 84. The normal range, it was slightly raised since it's above the normal range of 55. The AST was 152. The LP was 305. The GGT was 49, and the albumin was 24. The RFTs, we had the serum creatinine was 35, the BUN of 4.4. So where the child was being managed, they had done a blood smear for malaria and it was positive, but then we repeated on arrival and it was showed two pluses, and the MRD was reactive as well. And also, we also did a blood culture. The results came a few days later and showed there was no bacterial growth. So our impression was severe malaria anemia, and there was also thrombocytopenia, which we wanted to query the cause, and we thought it was due to the severe malaria. So we managed this child, and we gave intravenous, we gave IV artesunate, 57 milligrams at arrival, 12 hours later, and then at 24 hours. We transfused 190 mils of packed red blood cells. We transfused also with 190 mils of platelets, and we gave IV 10% dextrose, 20 mils for hourly, We gave also IV normal saline, 116 mils 2 hourly, and also we gave intravenous cefotaxime, 950 grams TID. So we also thought this child had a partial intestinal obstruction. So we called the ped surgery team to review the child, and their plan was to do the plain erect abdominal X-ray, to do an abdominal ultrasound scan, and the enema washout, and to continue the treatment. And they also advised the team to add IV metronidazole. So during our post-admission ward round, the next day in the morning, we still stuck to severe malaria anemia with the thrombocytopenia, and we are querying the cause. So the plan was to transfer our patient to Farm A, which we are from, and also to do a post-transfusion CBC, to do a peripheral blood filling, and to continue with the treatment that we had initiated earlier. So the post-transfusion CBC done that day was 7.2 grams per deciliter. The platelets was at 5,100 per liter. The white blood cell count was 16,420. Neutrophil count was 2,370. The lymphocytes was at so the PBF showed reduced platelets, but were normal in size. There were no atypical cells. There were no abdominal scan findings. The plain erect abdominal X-ray showed gaseous distension of bowel loops, no features of bowel obstruction. So on the 30th, the child reported no new complaints, no fever, passed stool the previous day, and bowel sounds were heard. So the plan was to do HB electrophoresis using the pre-transfusion sample that we had taken at acute, and also to do a post-treatment BS. Yes, thank you.